So, based on what we've learned about, red blood cells, white blood cells, platelets, a few things about abnormalities related to various cell types. I'm going to start with red blood cells. So, two conditions that I would like to mention here. First is anemia. So there are basically several main causes. So iron deficiency, okay, and bone marrow problems. Well, okay. Well, the third one is B12, vitamin B12 deficiency. So you have iron deficiency anemia, you have bone marrow problems, it's aplastic anemia, and deficiency of the vitamin B12, the vitamin that is required for fast dividing cells, is called pernicious anemia. So iron deficiency anemia, if the deficiency is dietary, can be fixed, obviously, by consuming iron. Bone marrow aplastic anemia, that's a bone marrow problem, bone marrow transplantation. Vitamin B12 deficiency is either dietary, because diet doesn't contain enough B12, usually does. Another issue, some people do not produce, if you remember from Unit 2, intrinsic factor, the protein that is produced in the stomach and is required to B12 absorption. So people that do not produce that intrinsic factor can have pernicious anemia. Another problem associated with red blood cells is sickle cell anemia. It's I put it as a separate sort of condition. So what happens in sickle cell, the hemoglobin A, due to the mutation in the gene, is not produced, and instead hemoglobin S is produced. And in the areas of the parts of the circulatory system where oxygen partial pressure is low, accumulation of hemoglobin S results in the sickle cell formation. And formation of sickle cells results in the vascular damage, hemolysis, obviously, red blood cells are dysfunctional, hypoxia, inability to deliver oxygen to the tissues, and often kidney failure. Now, one interesting feature of sickle cell is that it is a I forgot the term. Jesus, not sex-linked, not X-linked, recessive. So basically, it's one of the chromosomes. It's not linked to the sex chromosome, not to the X chromosome, but some other chromosome. The point is, it's a recessive condition. So people who are either homozygous recessive, obviously, or heterozygous, they become resistant to malaria. The mechanism is really interesting because, especially, so here's the deal. For homozygous people who are homozygous recessive people who have sickle cell anemia, resistance to malaria is not much of an advantage because they're already pretty in a pretty bad position, especially if it happens in the malaria endemic regions like Central Africa, for instance, Sub-Saharan Africa. Then having sickle cell anemia is basically a death sentence because there's no reliable treatment. There's no hospital where they can go to regularly, and money and stuff. But if they are heterozygous, this is an example of incomplete dominance. So small amount of hemoglobin S will be accumulated in heterozygous people. Does that make sense? So they're going to be how to say, healthy otherwise. But if they get infected with malaria parasites will infect red blood cells, and that infection will trigger the transformation of an infected red blood cell from normal, donut-shaped, so to say, to the sickle cell. Sickle cells are abnormal, and spleen will get rid of them. So those malaria parasites are almost immediately destroyed. And this is why people who are heterozygous have a fitness advantage in sub-Saharan Africa over people who are homozygous dominant, people who do not have that gene. And this is a good example of how a gene that apparently, is just functional can still persist in the population if carrying this gene provides some other fitness advantage. Does that make sense? Now, obviously, the white blood cells associated disease, we call it generally, leukemia. Now, there are gazillion types of leukemia. There are B cell, T cell, even monocytic leukemia. B and T cell leukemias are more common. If I remember correctly, T cell leukemias tend to be more acute with a fast development, so they're more dangerous, And B cell leukemias tend to be more chronic. And I must tell you this phenomenal story. So there's a treatment which is called CAR T-cell therapy. Not for the exam, you can put your pencils down, it's just so good. I hope I will be able to recite it properly. So this is the treatment for B cell leukemias, very specific. So this is what happens. The T cells of a patient, I know we didn't talk about T cells yet, but basically have two types of cells that provide you adaptive immunity that can attack very, very specific molecules, okay? So physicians would take blood, would isolate T cells. That makes sense? I think it is bone marrow. I think they take bone marrow. And they take T cell precursors from the bone marrow. And they modify them with the very much mangled HIV virus. Seriously mangled. So basically it's HIV that cannot do normal HIV stuff, right? But this modification makes those new so-called chimeric T cells to attack the B cells. And remember, we're talking about the patients in whom B cells, they not normal. So then those modified T cells are injected, so to say, into that same patient. So there's no rejection, nothing. Injected in the same patient, they proliferate, differentiate, and start attacking patients' dysfunctional B cells, which is crazy. So the effect of this therapy lasts for a long time, okay? Several years. I mean, it works pretty good. And the main concern is that if you destroy one kind of immune cells, it's not good, right? Well, it turns out it's not too bad. And those patients live pretty normal life, even without B cells. The only downside is the price tag for the treatment, which averages about $450,000 per patient, like the whole procedure. Yes, but and recently it was approved. It was originally approved, as far as I remember, for adults. Now they approved it for children as well. I don't know if insurance companies cover it or not, but it's insane. as soon as it will become more and more common and usual, the price should go down. Okay, this is just great. Now, what about platelets? So in platelets, we're talking about two conditions. One of them is thrombocytopenia. So this is basically inability to produce platelets, lack of platelets. Often thrombocytopenia is secondary, so it's a result of infection. Usually results, you can kind of clearly see bleeding under the skin, so-called petechia. Another condition associated with platelet dysfunction is excessive clotting. Okay, and the risk factors for excessive clotting is platelet activation, and we talked about platelet activation before. So main risk factors include things like atherosclerosis, hypertension, obesity, diabetes. Now, if you think about it, it makes sense. Remember, we're talking about platelets playing a role not only in thrombosis but also in inflammation. So all these conditions are characterized by the chronic low-grade inflammation. And this inflammation activates platelets, and they tend to form clots in inappropriate locations. Like, there's no damage, but they will clot. If this clot is dislodged, which often is the case if coagulation cascade is not activated. Clot is formed, it's not particularly reinforced, but it's still formed. It dislodges, it travels through the blood vessels, ends up in the heart attack, ends up in the brain, ischemic stroke. Does that make sense? So this is why the main, so people take aspirin, so we have some aspirin, inhibits thromboxane A. So it's a pretty strong inhibitor of platelet activation. We have some other heparin, obviously. Heparin is anticoagulant, so it inhibits coagulation cascade. I don't remember from top of my head which step. We have a lot of thrombin inhibitors, okay, such as Predexa or, yeah, my fantasy stops at Predexa. That's the only brand name that I remember. So basically, if you inhibit thrombin, the fibrinogen is not converted into fibrin. Does that make sense? Remember the common pathway when you have prothrombin activator activates prothrombin into thrombin, and thrombin then activates fibrinogen into fibrin. So if thrombin is inhibited, then fibrin threads are not formed. So people often take those drugs like if they run high risk of thrombotic events. Does that make sense? Good? Okay.